Module 6, Endocrine. So this recording will cover Chapter 44, Coordinating Care for Patients with Diabetes Mellitus. So first we start with defining diabetes. So the textbook definition is a group of disorders characterized by elevated blood glucose levels and results from defects in insulin production, insulin action, or both. So what this means is there's an issue with insulin. The pancreas is what produces insulin. So either the body isn't making enough, or it's making enough and our cells just can't use it, or the body is just not making any insulin. So that is all considered diabetes, which is essentially hyperglycemia. Let's do a review of insulin and glucagon. So these are two hormones produced by the pancreas. The pancreas is made up of alpha cells, beta cells, and delta cells. We're going to focus on the alpha and beta cells. So insulin is produced by beta cells and glucagon is produced by alpha cells. And insulin and glucagon oppose each other. So this means that insulin's goal is to decrease blood glucose in the blood, and glucagon, its goal is to increase blood glucose in the blood. And by these two working hand in hand, our body is able to maintain normal levels of blood glucose. So insulin. So we know that insulin acts as a key that unlocks the door to the cell to allow glucose in so that our body can use it as its preferred energy source. Glucagon is released by the pancreas when our blood glucose goes too low. And glucagon is a hormone, it's a messenger that will tell our liver to convert stored glycogen into glucose. When you have a normal functioning pancreas and endocrine system, insulin and glucagon are able to pretty much maintain our blood glucose levels at a normal range. And our normal range, according to this textbook, is going to be 65 to 99, and that is a fasting blood glucose. And this mechanism, this well-oiled machine between insulin and glucagon, will control blood glucose despite how old the person is, how much they weigh, what they eat, and what type of activity level they have. So for example, you could have a patient who is 6'5" in height, weighs 300 pounds, eats 5,000 calories a day. But if they have a normal functioning pancreas, the body is able to maintain that glucose between 65 and 99 pretty much at any time. The major classifications of diabetes are listed here. We have type 1, type 2, gestational, which occurs during pregnancy, and then we have this other category where diabetes is associated with other conditions or syndromes, which we will talk a little bit about. The main focus of this recording is going to be type 1 and type 2 diabetes. Now let's talk about the difference between type 1 and type 2. So really important that you distinguish the two. Okay, so type 1. Type 1 happens abruptly, it's acute, it is sudden. It can happen at any age, but usually it's going to be below the age of 30 or more commonly below the age of 10 years old. The patient will be thin in appearance. Again, this slide is referring to at time of diagnosis. So the patient will have lost weight unintentionally recently. Risk factors include genetics and environmental triggers, and this is not fully understood. We are not 100% sure on why this happens. This is an autoimmune response where something triggers our immune system and it attacks our beta cells in the pancreas, and the pancreas ends up no longer being able to produce insulin. So some environmental triggers they believe to play a role in this are mumps, rubella, toxic chemicals, possibly cow's milk, and cytotoxins. So with type 1, these patients produce no insulin. That is a very big difference between type 1 and type 2. Because of that, these patients require exogenous insulin to live. So they need injected insulin multiple times a day for the rest of their life. Type 1 diabetics are also prone to ketosis. So what is ketosis? So what are ketones? So ketones are a byproduct of fat metabolism. So if you burn fat, naturally you will create ketones, and ketones are acidic. So if you have a lot of ketones, it will eventually spill out of your blood, it will spill into your urine, and you will end up with a condition called diabetic ketoacidosis. Now, per textbook, type 1 diabetics are usually paired up with DKA, and then type 2 diabetics, their complication is something called HHS, and we're going to talk about the differences in a moment. So because type 1 patients have no insulin, their pancreas is not making any insulin. That means that their cells are going to be starved from glucose very, very quickly versus a type 2 patient. So if you don't have any glucose, your body is going to start the next best thing, which is going to be fat. So these patients, that's why they are thin in appearance at time of diagnosis, because their body is starving for glucose, which it can't have because of the lack of insulin. So it's going to start burning fat as an energy source. Patient will lose a lot of weight, but they're also going to produce a lot of ketones. So those ketones will keep adding up, and the patient will end up in ketoacidosis, which is life-threatening. Remember, acidosis is incompatible with life. So in this class, we're not going to go too much into the management of DKA, but since it's a complication of this, we are going to touch upon just your priority interventions as a nurse. So if you have DKA, you will likely be treated in ICU, so in a critical care setting, and you're going to have a couple of priorities. So you're going to have hyperglycemia, so a really high blood sugar, and usually at least 250 or above, and patient is going to be very dehydrated, and that's because, remember, the 3 P's. Patient is going to be very thirsty, and they're going to be peeing a lot. That's the body's way of trying to manage that increased osmolarity in the blood because of all of that extra glucose. Okay, so patient is going to be very dehydrated, and they're going to have a high blood sugar. So priority-wise, if you had to choose, you're going to give the patient fluids as your priority. So I want you to remember that. Fluids, then you're going to treat the hyperglycemia with insulin. Okay, so let's move on to type 2. So unlike type 1, this is a gradual onset. It doesn't happen overnight, and you can be also diagnosed at any age, but usually it's going to be over the age of 30. These patients are typically obese at diagnosis, and they're going to have risk factors. Okay, so unlike type 1, that's autoimmune. Type 2, you have lots of risk factors. So BMI above 26, sedentary lifestyle, high cholesterol, metabolic syndrome, which we will talk about on the next slide, or prediabetes. So with type 2 patients, there is a decrease in insulin production, or an increased production of insulin, but with insulin resistance. So with this, the takeaway is that the pancreas is still producing insulin. Even if it's not as much as before, it's still producing insulin, and the patient has insulin resistance. So the insulin that's there, it's having a hard time getting it to unlock the door so that the glucose can go in the cell. So with type 2, this does have potential to be controlled with dietary changes and lifestyle changes and losing weight if the patient is obese. These patients can be treated with oral medication, so oral anti-diabetic medication, or insulin, or a combination of the two. If the patient is put on insulin, it could be short-term or long-term. Now, the complication that's most associated with type 2 is something called HHS, or hyperglycemic hyperosmolar syndrome. The main difference between DKA and HHS is that HHS doesn't have a pH difference. So you're not in acidosis with HHS. DKA, you're in acidosis. That is the main number one difference. The treatment is going to be very similar. This patient will present with a very high blood sugar, usually at least above 300. I've seen in practice over 1,000 blood sugar level. That's because it's a gradual onset. It's been going on for a while, and they still make a little bit of insulin, just enough insulin to keep them out of acidosis from those ketones. So that is the main difference between HHS or DKA. Now, in practice, you might have seen a type 2 diabetic in DKA. So what is that about? Okay, so for NCLEX purposes and your course exam purposes, they tie type 1 to DKA and type 2 to HHS. But in real life, you will see type 2 patients going into DKA. So let me just tell you why that is. So for a type 2 diabetic who has had uncontrolled, unmanaged diabetes for a long time, their pancreas is working overtime. It's trying to produce insulin because it senses that the blood sugar is too high, but it's not working because of the insulin resistance. So it's overworked, and eventually it's going to be so overworked, it's going to stop producing insulin maybe completely or just a little tiny bit. So those patients will be called type 2 diabetes, insulin dependent. So insulin dependent type 2 diabetics. Now that doesn't make them a type 1, it just means that they are now insulin dependent because of their situation. Now those patients are prone to DKA because again, DKA happens really fast when you don't have any insulin at all. Okay, so that is the difference. Make sure you understand the difference between type 1 and type 2. One thing to also note is metabolic syndrome. So when you have this group of risk factors, it puts a patient at risk for diabetes or cardiovascular disease. And listed here we have abdominal or central obesity. So this is when you hold a lot of your extra weight in your abdominal area. If you have high triglycerides, if you have decreased HDL and high LDL, if you have hypertension, and if your fasting blood glucose is greater than 100. So all of these things are modifiable. So if your patient has any of these symptoms or signs, then this is an educational point so they can hopefully reverse them or decrease them and putting them less at risk for cardiovascular disease or type 2 diabetes. So then we're going to talk a little bit about the other category when it comes to diabetes. And this can result from pancreatic conditions or diseases, hormone issues, medications, trauma. And I just wanted to add this in just to make you aware because in the clinical setting you will see these things. So first off, the first picture, we have an injured pancreas that can be from a tumor, can be from cancer, that will impair the pancreas's ability to make insulin in some cases, so the patient will then become diabetic. Medications, as pictured here, you see those are corticosteroids. Those cause hyperglycemia. So sometimes if your patient, especially if they are getting steroids through the IV route while they're in the hospital being treated for some type of inflammatory process, then those patients might be placed on an insulin sliding scale during their hospital stay, and then that would be discontinued once they're off that medication. So that would be like a steroid-induced diabetes. Then the third one is trauma. You can see in the picture, anything can happen with a trauma, a car accident, a fight, a gunshot wound, a knife wound to the pancreas, and then the pancreas wouldn't be able to optimally function. All right, so we're going to move on to our clinical manifestations of type 1 and type 2 diabetes. So there's a lot of overlapping because both are hyperglycemia. So the 3 Ps, polyuria, polydipsia, polyphagia. So the patient is voiding a lot, they're real thirsty, and they're hungry. So they're thirsty because they're dehydrated and the body is trying to diurese that extra blood sugar, trying to get it out of the body. Polyphagia, they are hungry because their cells are starving for energy. So it's kind of giving a message to your brain to eat more. Okay, so type 1, we have the 3 Ps, fatigue and weight loss, which is what we talked about from burning all of that fat. In type 2, remember this is gradual, so they're also going to have the 3 Ps, but because this is happening over time, we're also going to see poor wound healing. They probably have cardiovascular disease. They may have some visual disturbances, oftentimes because prolonged hyperglycemia, it really damages all of our blood vessels from head to toe on the micro and macro level. So in our eyes, we have these tiny little vessels that are sensitive to things floating around in there that shouldn't be floating around. So patients may have some blurry vision or other disturbances, and that's what prompts them to go to the hospital. Renal insufficiency and recurring infection. So a female may have recurring yeast infections, and that could sometimes be a red flag that they're pre-diabetic or they have diabetes. And then here it says pre-diabetes is asymptomatic, but long-term damage already occurring. So with pre-diabetes, because this takes a long time to manifest, you don't see any of the symptoms, but things are already changing physiologically on the inside of the body. So how do we diagnose diabetes? So we base this on a few things: fasting blood glucose, a 2-hour postprandial blood test, hemoglobin A1C, or random blood glucose level, or a combination of 1 to 2 of those. So these numbers are important to remember. So fasting blood glucose, this is like at least 8 hours of fasting, usually done first thing in the morning. If they take your blood sugar and you are between 100 and 125, you would be considered pre-diabetic. If you're above 126, you have diabetes. 2-hour postprandial, that means that you ate a meal and then we checked your blood sugar 2 hours after that meal. So again, if we tested your blood sugar and it was 140 to 199, you're considered pre-diabetic. And if your blood sugar still remains high, over 200, and it's been 2 hours since you ate, you would be considered to have diabetes. Next is a hemoglobin A1C. Now this one I want you to pay extra attention to because this measures our average blood glucose levels from the last 2 to 3 months. So this is a great indicator on how well controlled a patient's blood sugar is and if our interventions are effective. So the pre-diabetic range would be 5.7 to 6.4, and then diabetes would be higher or greater to 6.5%. Then we have our random blood glucose level, so you're not fasting, you may have just eaten, you may have not, and if it's greater than 200, and you have other signs and symptoms of hyperglycemia, like maybe those 3 Ps, then they may also say that you have diabetes. So these numbers are very important to know. A complication that can occur from both type 1 or type 2 diabetes is hypoglycemia. And per our textbook, this is the blood glucose level less than 65. So depending on where you work, that number might change. So for right now, we're going to say 65 is considered a low blood sugar. So this happens when there's too much insulin in proportion to glucose in the blood. So we've used up all of our glucose and now we are hypoglycemic. One thing to note is that we do have other mechanisms that help to regulate our blood sugar when we go hypoglycemic. So we have these neuroendocrine hormones like epinephrine, norepinephrine, and glucagon, which we talked about before. Our sympathetic nervous system is going to be activated, and we'll talk about what that means in a moment. Okay, so causes of hypoglycemia: too much insulin. Risk factors: decreased nutritional intake, so you just didn't eat enough, increased metabolism of glucose, so maybe you're exercising more than usual, alcohol, and hypoglycemia unawareness. So hypoglycemia unawareness often happens with people who, this isn't the only reason, but most commonly is when you tend to run hypoglycemic very, very often, and then your body just kind of adjusts to that. So you don't show signs and symptoms until you're really, really low, versus somebody who maybe if they're at 70, they're already showing signs of hypoglycemia. Okay, so the central nervous system relies solely on glucose for its energy needs. So it has to maintain a constant supply in order for those brain cells not to die. So that is why when you are having signs and symptoms of hypoglycemia, your body is getting very, very uncomfortable. And if we don't correct it, our central nervous system will become affected and we will see neuro signs and symptoms. Okay, so let's go back to these clinical manifestations. If you are hypoglycemic, you may experience anxiety, hunger, palpitations, circummoral paresthesia, which is like tingling around the mouth and lips, sweating, dampness, shakiness, and irritability. If the hypoglycemia is not corrected, then again, like I just mentioned, the central nervous system will start to kick in. You will have slowed thinking processes, dizziness, fatigue, slurred speech, lack of coordination. And if still left untreated, the patient can experience seizures and slip into a coma and die. So how do we treat hypoglycemia? We're going to use the rule of 15. Now, when you are in the hospital or whatever facility you're at, their hypoglycemic protocol may be a little bit different, but it will typically be a version of this. So rule of 15 is 15 grams of oral glucose. So that is 1 serving of a fast-acting glucose. So something like juice, regular soda, not diet, honey, jelly, graham crackers. You want to avoid foods with fat because fat can make it take longer to be absorbed, and we want fast-acting glucose. After you give your patient your 1 serving or 15 grams, you're going to recheck their blood sugar in 15 minutes. That's where the rule of 15 comes in. And if they are still hypoglycemic, then we do it again, and we keep giving them 1 serving, waiting 15 minutes, and then rechecking. Once they become no longer hypoglycemic, so maybe they are now 70 or 80, then you want to give them a snack just to kind of hold their sugar in place. You want to avoid overtreatment because if their sugar goes really high, then you have to treat it, and it's just like a ping pong ball effect. Okay, so in the hospital setting, you may have access to dextrose 50%, also known as D50, as an IV push. So you're going to go by your orders and what the criteria is for administering that if necessary. But generally speaking, for our purposes, if the patient is alert, able to follow commands, and can swallow safely, and they're hypoglycemic, we are going to try to give them oral glucose. Now, if they're in the hospital setting and they don't have IV access or they're not able to swallow, because remember, when you're hypoglycemic, you will eventually become lethargic and you can slip into a coma. So if that's what's happening and you're not able to administer anything through the IV route or the oral route, then we have glucagon as an option. So remember, glucagon is that hormone that the pancreas produces that tells the liver to release its stored glycogen so that we can use that as energy. So that is the last ditch effort. So here pictured, you can see what it may look like here. This is a glucagon kit that is sometimes prescribed home, so patients can have this as an emergency kit. So you may have access to that in the hospital, or you may have the vial version like this where you reconstitute it and you give it intramuscularly. Two other complications that may occur with diabetes, more commonly with a type 1 diabetic patient: the Dawn phenomenon and the Somogyi phenomenon. So we're not quite sure why these happen. That's why they're called phenomenon, but let's talk about it a little bit. So we have the Dawn phenomenon. This is where the patient goes to sleep at night with a normal blood sugar, and then sometime in the early morning hours between 5 and 8, they become hyperglycemic. The patient didn't eat anything overnight, they didn't do anything, they were just sleeping. So it's believed that this is a result of naturally occurring hormones while we're sleeping, and it just causes the blood sugar to rise. So like glucagon, cortisol, growth hormone, those can all affect our blood sugar. Those three are all things that are that make our blood sugar go up. So the reason why we're aware of this, or that we should be aware of this, is because sometimes we need to keep that in mind, and their insulin dosing may need to be adjusted to cover that Dawn phenomenon. Second one is the Somogyi phenomenon. So this is where the patient goes to sleep. They may have a normal blood sugar or maybe a little bit increased, and then somewhere around 2 to 3 in the morning they have a hypoglycemic event, and it wakes them up and they have really low blood sugar. So again, this is thought to be a result of counter-regulatory hormones, and then by the time they wake up, they're actually hyperglycemic. Okay, so they go to bed normal or a little bit high, then they go really low around 2 to 3 a.m., and then they wake up high. Again, the reason why you should be aware of this as the RN is because you might see these blood glucose variations, and usually we can treat this with adjusting their insulin doses or maybe giving them a snack before bedtime. Just depends on the situation. As we know, diabetes wreaks havoc on the body. You know, whenever you have a patient in the hospital, 9 times out of 10, they have diabetes. So let's talk about the chronic complications of diabetes. So when you have a lot of extra blood glucose, so prolonged hyperglycemia, it's going to start to affect our blood vessels. So the elasticity of the blood vessels decreases, and it causes them to become stiff and narrow. And if you remember, our blood vessels should not be stiff and narrow because that's going to cause problems. So that's exactly what diabetes does to the whole body. Like I mentioned, it's the micro and vasculature, not just the big vessels, but those tiny little vessels throughout our body. And this is going to lead to hypertension, decreased perfusion, and atherosclerosis. So this is just a picture of all the things that can happen as a result of uncontrolled diabetes. As you can see from head to toe, every organ is affected. So we're going to talk about how we use insulin to treat diabetes. But before we do that, we need to understand the normal insulin metabolism in a healthy person. So we're talking about somebody who has a optimally functioning pancreas. So for a healthy person, their pancreas secretes insulin 24 hours a day, 7 days a week. There's always a little bit of insulin being produced. When the person eats food, then the pancreas is aware and it starts to produce more insulin to cover that meal. And it works this way to keep our blood sugar between 70 and 120, whether we're eating or we're not eating. So this is how we want to mimic the insulin that we give patients. So this one, the first bullet here where it says insulin is continuously in the bloodstream in small increments, that's going to be our basal insulin. And then the second one, where insulin is given for a meal, that is our bolus. So if you look at this table with the types of insulin, you see bolus, bolus, basal, basal. So we are going to bolus a patient when they are eating. These are short-acting, rapid-acting insulins. It's just aimed to cover whatever that patient is consuming at that time. The basal insulin, which is intermediate-acting or long-acting, that is going to have a longer effect. There is no peak time in the long-acting, and that is going to act in the background, hopefully for the whole day. And this aims to mimic the body's natural secretion of insulin. Okay, we're going to talk about oral anti-hyperglycemic medication. So let's take a look at this chart here. So the first one at the top is metformin. That is going to be the gold standard. It's a really old medication. It's been around for a long time, and it is still the medication of choice for a patient who has just been diagnosed with type 2 diabetes. So this mechanism of action, and I'm not going to go through all of these, I'm just going to go through metformin. This decreases glucose production in the liver. So remember when we go hypoglycemic and then glucagon is released and it goes to the liver and then the liver dumps out whatever storage it has? Well, this is going to decrease that process, and it's also going to increase insulin sensitivity in skeletal muscle. So these patients don't typically go hypoglycemic because they took their metformin. Okay, so that's something good. Now, what you want to remember is that metformin is renally cleared. So patients that have renal impairment may not be able to take metformin depending on what their current kidney function is at. So if a patient is taking metformin, we want to make sure that they are following up with their provider to get routine blood work to make sure their kidneys are okay. Another thing about metformin, because it is renally cleared, we have to be careful with patients who are on metformin who are going to receive an iodine-based contrast. So if they're having a CT scan with IV contrast, this is contraindicated, so it's something you need to report to the physician. That's another reason why we don't typically continue patients' home oral medications for their diabetes in the hospital. We will temporarily switch over to insulin during their stay because we can have a better, tighter control of that medication. I'll let you read through the other medications on your own, but just remember metformin is the gold standard. So for prediabetes, we want to prevent this from turning into diabetes. So we want to make sure we're identifying and monitoring and teaching patients who are at risk of developing diabetes. So if we have a patient with risk factors such as family history, hypertension, high cholesterol, large waist circumference, and so on, then we want to screen them. We want to check their blood sugar. We want to check their A1C to hopefully stop that progression. We want to educate on modifiable risk factors. This is huge in nursing. So lose weight if they're obese, become active if they're sedentary, and educate on a diet with low fat, high fiber, low sodium. And then a little recap on what metabolic syndrome is. So if you have this group of risk factors like hypertension, hyperglycemia, the fat around the waist, cholesterol or triglyceride levels out of range, then it puts you at greater risk for developing cardiovascular disease and diabetes. So we really want to focus on those modifiable risk factors when we can. Part of diabetes management is educating on nutrition. So nutrition is very important. If you're in the hospital setting, we want to make sure we make use of our multidisciplinary team, so like a dietitian or a diabetes educator, to help reinforce this information. So let's look at type 1 versus type 2 and what our goals are for each patient. So remember, type 1, there are no modifiable risk factors, so we're just going to focus on the patient's individual needs based on how often they exercise and their usual food intake. Of course, we always educate on balanced meals, but conversely, with type 2, we are going to emphasize on those modifiable risk factors, making sure their blood glucose are maintained, their cholesterol levels are managed, they control their blood sugar, they lose weight if they need to, and so on. So that is the biggest difference between how we educate on nutrition for type 1 and type 2. One thing to note is that type 1 diabetics have an option to get an insulin pump. So again, textbook wise, we are going to say that type 1 diabetics meet the criteria for an insulin pump, where type 2 usually isn't appropriate for that. So what is an insulin pump? It is a device where it's connected to the patient, and it kind of acts like an artificial pancreas. Now, we're a long way from an artificial pancreas being given to the public, but this insulin pump monitors the blood sugar along with a continuous glucose monitor, and it provides the insulin in the background at all times. So that is the quick version of what an insulin pump is, but it's mainly geared towards someone who doesn't make insulin at all. So that is why type 1 would benefit from an insulin pump. Okay, so carbohydrate counting, carb counting for short. So this is something you want to educate your patient on, because once they leave the hospital, they need to know a rough estimate on how much carbs they're consuming, not only to be aware, but because they may need to dose their insulin based on the number of carbs they're eating. So remember, one serving size of carbohydrates is 15 grams. And generally speaking, one meal is 45 to 60 grams. And this will be dictated in the hospital by the dietitian or the physician, or by standard orders, or an endocrinologist will give you something more specific. So this is per doctor's order. And insulin is going to be based on the number of carbohydrates consumed. And we're talking about carb counting. We're not talking about a sliding scale. And then we need to teach the patient this. So for example, you are teaching your patient how to count carbs, and they're looking at a package, a food label. You're going to show them where the carbohydrates are listed and how many servings are in that package. So let's say, for example, they're looking at a loaf of bread, and on the label it says that one slice is 15 grams. Okay, so you're teaching them where to look for the number, and once you get that number, then you go back to the doctor's order, and it's going to tell you what the ratio is. It's going to be 1 unit of insulin for a blank number of carbs. And that's really just going to depend on the physician, the endocrinologist, the patient situation. It's not something that you have to determine. This is a doctor's order. So say the order says 1 unit of insulin for every 5 carbs consumed. So if this serving is 15 grams, you're going to divide 15 by 5 because that's the order, and the answer will be 3. That is 3 units. Okay, so again, carb counting is using the provider order ratio. It'll say 1 to 5, 1 to 10, 1 to 15, 1 to 25. It really just depends on the patient, and that's how they're going to dose their insulin. If you have a carb count in the hospital, you wait till the patient eats the food they're going to eat, and then you count the carbs after, so you know how much to cover the patient. Let's talk about nursing considerations for certain situations. So exercise. So if a diabetic patient is exercising and they are on anti-hyperglycemic medications, whether it's oral or insulin, they should be monitoring their blood sugar before, during, and after exercise. And they should be aware that when you exercise, that effect where your blood sugar can lower can actually last up to 2 days. And that's actually a good thing, because that will help the patient take less medication. Exercise 1 hour after meal so that there's kind of like a stored glucose pot available, and maybe even take a snack to prevent hypoglycemia. One thing to note is that a patient should not exercise if the blood sugar is more than 300 and if ketones are present in the urine. So let's take a look at this. You would think, well, if your blood sugar is high, exercising would help bring down that number. Well, that is true. But if ketones are present in the urine, that means the patient is in ketosis. And if you exercise, you are going to be burning fat and creating more ketones. And we don't want to become acidotic. So the sugar is a little high. We're not going to worry about that in that situation, but we're definitely not going to exercise more because we don't want that acidosis to manifest. Next is nursing considerations in times of illness, aka sick days. So now your patient with diabetes is sick, so some education that you'll need to tell them. They need to stay hydrated, they need to check their blood glucose a little more often, and they should be prepared for hypoglycemia, and they should continue to take their medication. So the takeaway from here is that if you are sick, you still continue to take your insulin or your oral diabetic meds, because if you don't, that is what precipitates diabetic ketoacidosis. So sick day rules: stay hydrated and take your medications. If your patient is being discharged with insulin, and especially if this is the first time they've ever been prescribed insulin, there's a lot of educational points that the patient needs to understand before going home. So we want to educate them on a glucometer, not only how to use it, but when to use it, and then what to do with the number that they get. And this is best done with return demonstration. So they should be physically showing you how to do it. That's how you know that they know. Types of insulin, peak times, when to hold dose. So say they check their blood sugar. Now what are they going to do? What type of insulin are they taking? How to administer. So vial syringe, insulin pen, pump. So hopefully they have a pen, which is right here, because using a vial and syringe to draw up medication can be difficult for a seasoned nurse, let alone somebody who's not used to handling needles or maybe doesn't have the greatest vision or dexterity to hold a needle. So these pens are becoming more and more common, but again, they're a little bit more expensive and all insurances may not cover them. So you may still see vial and syringe patients being discharged with that. Injection sites. So we want to educate them, and I'm going to talk a little bit more on the next slide. How to store insulin, carb counting to dose insulin if the doctor has ordered that. Signs and symptoms of hyper and hypoglycemia. Emergency glucagon, so patients can be prescribed one of these emergency kits to take home. Again, this is to be used when the patient isn't able to take anything by mouth safely. So they're unconscious, maybe they're having seizures, or maybe they've even slipped into a coma. So this is where we're going to educate the caregiver and the patient on how to do this. So not everybody's comfortable with needles and being able to reconstitute this. So there actually is an intranasal glucagon spray that's on the market. So that's much easier to use. So that might be an option for the patient. We want to make sure we educate everybody who is around the patient, friends, family, caregiver, etc. And recommend home health if necessary, because we should be following up with these patients, especially if this is a newly diagnosed diabetic. So back to insulin. This is a high alert medication, so you want to be extra careful. So we usually give insulin by the subcutaneous route, and just to note, regular insulin may be given IV push. Insulin cannot be taken orally. The fastest absorption is going to be in the abdomen, followed by the arm, thigh, or buttock, but abdomen is the preferred site. We want to make sure that the patient is aware that different syringes have different measurements. So if they are using a syringe, we just need to make sure that they're cognizant of that. Injection is 45 to 90 degrees. So this is going to depend on the patient's size and how much adipose or fatty tissue they have. So 90 degree, if you see here, is the standard. Okay, so 90 degrees is standard, but if they have less adipose tissue, we may have to pinch skin a little bit and do it at a 45-degree angle just to make sure that needle gets into that subcutaneous space. We also want to educate the patient to rotate injections. Many times patients kind of pinch the same spot and keep injecting in that same spot. So you can see in this picture, lipohypertrophy. Lipo meaning fat, hyper meaning a lot, trophy meaning kind of like a big mass. So these little bumps, nodules can form these little fatty, these little fatty nodules that are kind of hard, firm. So this is what we're trying to avoid. This happens over time when the patient uses the same area over and over to inject their insulin. We've reached our last slide on patient education, preventing and managing complications. So the whole takeaway from this whole recording, we want to maintain normal blood glucose levels. That's going to be in combination with either oral meds or insulin and dietary adherence or compliance. Maintaining normal blood pressure. So take either lose weight to help with that or take your blood pressure medications. Follow up with provider regularly. A1C, so remember that is that 2 to 3 month average of blood glucose. It's going to establish a baseline, and then when the patient comes in every so often, we're going to check the A1C to see if it's working. Is the insulin working? Is the patient compliant? Do we need to change something? There is a goal. We want a patient that has diabetes to be below 7, so A1C below 7. Now you might think, well, that's kind of high because a normal A1C is 5.6 and below. If you make a goal that is low, say we said, hey, we're putting you on insulin, your goal is 5.6 because that is a normal A1C. then that means that that patient runs the risk of going too low and having hypoglycemia because we are giving them medication to lower their blood sugar, and that is just too close. Then the patient will have these other complications that we have to worry about. So based on this research, evidence-based practice, our goal for these patients are going to be an A1C below 7. We want to educate on stopping smoking if they smoke, lose weight or maintain a healthy weight, exercise regularly. We educate on at least 30 minutes a day, 5 days a week. Diet, low fat, low cholesterol, low sodium, low carbs or moderate carbs for a type 1 patient. Limit alcohol. Vision screening every year. Skincare, we want to avoid lotion in like the nooks and crannies, like in between toes. And foot care, we want to make sure we're educating the patients to inspect their feet daily, use appropriate footwear, so like closed toe shoes, be really careful with injury, and keep feet clean and dry. And that concludes this recording.